Hello everyone, welcome to Pharmacon tutorial. Today's topic is insulin. First let us see some general concepts of insulin. So as we know, pancreas are both exocrine and endocrine. The islets of Langerhans has various cells like alpha, beta and delta cells, even PP cells. These alpha cells synthesize glucagon, beta cells synthesize insulin and amylin, and delta cells synthesize somatostatin. Insulin is secreted in response to chemical, neuronal and hormonal mechanism. Glucose, amino acids and fatty acid will stimulate the beta cells and lead to the increased secretion of insulin. Stimulation of parasympathetic nervous system will increase the insulin release, whereas these islets of Langerhans have both beta 2 and alpha 2 receptors. Beta 2 receptor stimulation will lead to increased secretion of insulin, whereas alpha 2 receptors will inhibit the insulin secretion. About the hormonal, there are various hormones like GLP-1, GIP and gastrin which increases the secretion of insulin. After a heavy carbohydrate meal, the nutrients from the small intestine gets absorbed into the blood. In the blood, there are glucose, amino acids and fatty acids. This glucose is transported inside the beta cells via GLUT2, which is a glucose transporter. Once this glucose reaches the beta cells, it gets metabolized into ATP. This ATP reaches the ATP sensitive potassium channel, it binds to the ATP sensitive potassium channel and closes the potassium channel. So the potassium conductance is reduced. Once the potassium conductance is reduced, the cell membrane gets depolarized. Due to depolarization, the voltage gated calcium channels gets opened and the extracellular calcium ions enters the cell. This calcium activates the molecular motors and pull them towards the membrane, pulls this insulin containing vesicles towards the membrane. So it causes the exocytosis of the insulin. This released insulin has its effect on liver, adipose tissue and skeletal muscle. Insulin receptors are present on the cell membrane. These receptors consist of 2 alpha and 2 beta subunits. These alpha subunits are present extracellularly and these beta subunits are transmembrane proteins with tyrosine kinase activity. Binding of the insulin on these insulin receptors will activate the tyrosine kinase and phosphorylates the tyrosine residues. Insulin has both cytosolic and nuclear effect. So first let us see the PI3 kinase pathway. Phosphorylation of the IRS, that is the insulin receptor substrate, will lead to the activation of PI3 kinase. Here this in the cell membrane there is PIP2, that is phosphatidyl inositol 4,5 bisphosphate. It is converted to PIP3 which activates the protein kinase B. This protein kinase B enzyme causes the translocation of the GLUT present on the GLUT4 vesicle towards the cell membrane, which leads to the entry or the promotion of glucose from outside to the inside the cell. Insulin also promotes gene expression and growth regulation by activation of the MAP kinase pathway. Now let's have a look at the insulin therapy. Insulin is the main drug for all patients with type 1 diabetes mellitus and for patients with type 2 diabetes mellitus who are not controlled by diet and oral anti-diabetic drug. Since insulin is a peptide, it is destroyed by the proteolytic enzymes in the gut and hence not effective orally. So they are administered by subcutaneous route or by IV route. Pharmacologically active insulins are of two types, that is coming under insulin preparation and insulin analogues. These conventional insulin preparations are obtained from beef and pork pancreas. This bovine insulin, it differs from human insulin by 3 amino acid residues and is more antigenic to man. Whereas the porcine insulin, it differs from human insulin by only one amino acid residue and it is less immunogenic. This monocomponent insulin is obtained by purifying the porcine insulin. And about the human insulin, it is obtained by the recombinant DNA technology, and it is same like endogenous insulin. The antigenicity is less, and their lipodystrophy is also less. Example of such an insulin is the regular insulin, that is human NPH insulin. Now moving on to the insulin analogs, they are prepared by the recombinant DNA technology but have a slightly different structure. Then depending upon their pharmacokinetic activity, they are classified mainly into rapid acting, short acting, intermediate acting and long acting. Example of this rapid acting is the Lispro, which is given IV, and the onset of action is 5 to 15 minutes. The peak reaches with 30 minutes. And about the short acting, regular soluble insulin, the onset of action is 30 minutes and it reaches at a peak of 30 to 45 minutes. NPH or isophane insulin is the intermediately acting insulin and the onset of action is 1 to 2 hours and the peak reaches at 6 to 10 hours. This Glargine is the long acting insulin. Its onset of action is 2 to 5 hours and reaches a peak for 5 to 24 hours. And the duration of action is about 24 hours. Now let's have a look at the drug interaction. Insulin shows drug interaction with beta blockers. Mainly these beta blockers will inhibit the glycogenolysis and they will delay the recovery from the hypoglycemia. They will mask the warning symptoms of hypoglycemia like tachycardia, palpitation and tremor. And the second drug interaction is with the salicylates. The salicylate exerts hypoglycemic effect by increasing the sensitivity of the pancreatic beta cells to glucose and they will potentiate the insulin secretion. Now moving on to the complications. Hypoglycemia is the most common and the dangerous complication and the prolonged hypoglycemia will cause permanent brain damage. Secondly, allergic reactions are seen even though rare. They will cause local skin reactions like swelling, redness at the site of injection and this is due to the minor contaminants. Lipodystrophy is seen at the site of the injection and it can be avoided by using purified insulin preparation and changing the injection site by rotation. And about the insulin resistance, both acute and chronic insulin resistance are seen in patients. Edema due to salt and water retention is also another complication associated with the insulin therapy.